previous topic, we talking about the personalization in ARDS. Now we're going to talking in the personalization in asthma treatment. So Dr. Bandan will coming up with the topic role of anti-leukotriene in asthma control from general guideline to personalized medicine. Dr. Bandan is assistant professor from pulmonology department of pediatric Thammasat University. Please welcome Dr. Bandan.
Thank you so much for a nice introduction to me. And first of all, I have to thank the Organon for supporting this luncheon symposium. My first topic is to cover about the role of anti-leukotriene treatment in asthma control. And I will focus to bring us from the general practice guideline to personalized medicine. And I have something to discuss to you. This lecture has been supported by Organon, but however, the content of this lecture was prepared by myself, not by Organon. And to be honest with you, I always use the evidence medicine manner to deliver the content in this lecture. And Organon does not modify any content in this lecture. And I'm talking about the role of anti-leukotriene in asthma control. And I will focus on how to use multi-leucas in asthmatic patients in order to get their best outcome. And as we know now, asthma is not only the bronchoconstrictive airway anymore. It is a chronic airway inflammatory disease. So we have to use the treatment to control the inflammation, not just the bronchodilator to dilate an airway anymore. And how to control asthma properly? So we have to deal with the inflammation of the airway, not only the bronchoconstriction of the airway. And if you think about the anti-inflammatory treatment, we might think firstly with the inhaled corticosteroid, right? So to be honest with you, I will show you the latest guideline in the GINA guideline. They divided the treatment option into the two groups. The first one, GINA called as the preferred controller option, which you still see the inhaled corticosteroid is within the preferred controller option at any step of asthma controller. But in the other hand, if we look at the alternative option, we will find that leukotriene receptor antagonist will be located in the other controller option. Why the GINA guideline recommend us like this? If we see the many RCT to compare between the inhaled corticosteroid with the multi-leucas, I will honestly tell you that the inhaled corticosteroid in the big picture has a better outcome in terms of asthma control compared with the multi-leucas. That is why GINA guideline recommended us we should use the inhaled corticosteroid as the preferred controller asthma option. But we already know that asthma has a multiple inflammatory pathway, which is included of the leukotriene pathway. And multi-leucas can block what we call as a systemic leukotriene. And the role of leukotriene in asthma pathogenesis is asthma airway inflammation and as well as asthma, what we call as airway remodeling or thick obstruction or airway fibrosis in asthma as well. And if we perform the allergen challenge test in the atopic asthma, we will find that the leukotriene will is going very, very high quickly after antigen challenge test was performed. So the leukotriene is the important pathway in terms of inflammation in the airway of asthmatic patients. Interestingly, if you think the steroid is the best anti-inflammatory medicine, but in this study, they gave the asthmatic patient for oral penicillin oral penicillin for about 1 week, and then they performed the allergen challenge test. Interestingly, both of patients who receive placebo and who receive oral penicillin cannot completely block the inflammatory mediator in the leukotriene pathway. The urine leukotriene E4 was going up in both of the patients who received the placebo and penicillin. So that is spiking us that we can use inhaled corticosteroid and get a better outcome for most, but we cannot completely control inflammation by using just inhaled corticosteroid if our patient have the inflammation in the leukotriene pathway as well. And this study is very interesting. If we compare between the first asthma control between the inhaled corticosteroid and with the montelukast, we will find that most of them, about 2/3, will respond better with inhaled corticosteroid, but the remaining 1/3 will respond best with the montelukast rather than inhaled corticosteroid. So it's unlike all or none story. It's like a some and some story. Some respond best with inhaled corticosteroid. Some will respond best with montelukast. As a clinician, we just have to find that with the patient in front of us at the OPD, at the clinic, which patient will locate it in this group or in the other groups. And I will tell you about this interesting study a little bit. The study performed in the asthmatic patient in the child who cannot achieve the asthma control after inhaled corticosteroid was prescribed. So if you think with the asthmatic patient which do not achieve asthma control with inhaled corticosteroid, what we have the option. The first option might be increases dose of inhaled corticosteroid. The second option may be add something like a leukotriene receptor antagonist. And another option may be we can add a long-acting beta-2 agonist to do this kind of patient, right? So the study include all treatment options into every single patient in this study. So the option A may be double dose of inhaled corticosteroid. Option B is adding of the leukotriene receptor antagonist. And the option C is add long-acting beta-2 agonist. So every single patient exposed to treatment A, B, C, and turn over amongst the 16 periods of week and turns to A, to B, to C. So everyone got treatment option. Interestingly, if we focus on the treatment outcome to focus on the leukotriene receptor antagonist, if we compare the leukotriene receptor antagonist with the long-acting beta-2 agonist, we will find that most of them will be respond better with long-acting beta-2 agonist, approximately 50%. But the remaining 35% will respond better with montelukast rather than adding of long-acting beta-2 agonist. And if we compare between leukotriene receptor antagonist with the double dose of inhaled corticosteroid, we will find that equally approximately 45% of each group will be respond better with double dose of inhaled corticosteroid. The remaining 45% will respond better with the adding of montelukast. And interestingly, every single patient exposed to the treatment option A, B, C, right? And approximately 30% will be respond best with adding of montelukast. So it is none all or none again. It is a story of some response to something better with the other. So we have to find the right person that we have to put the right medicine to the right person. So that is why asthma treatment should be personalized treatment, should not be give the all medicine according to the guidelines say, and you do not expect that every single patient will be respond to the treatment in the same way anymore. So if the common sense that, and we know that the steroid cannot completely inhibit the inflammation by the leukotriene pathway. So the one who have the inflammation who have the high level of inflammation from leukotriene pathway should be respond best with anti-leukotriene treatment, right? So if we can measure every asthmatic patient with the urine leukotriene, and we pick up the one who have the high urine leukotriene in the clinic and give them the montelukast, that is an easy story to do like that. But unfortunately, we do not send the urine leukotriene to the lab in every patient at our clinic, right? So if we look at this study, if we found that the patient will have a higher level of urine leukotriene, and we compare the treatment outcome in terms of FEV1 improvement, we will find that in the asthmatic patient who have higher level of urine leukotriene E4 will be respond better with montelukast compared to the fluticasone or inhaled corticosteroid. So I will bring us to find the right patient who supposed to have the high inflammation come from the leukotriene pathway. The first one is the asthma with the AR comorbidity. If we perform the nasal challenge test in the asthmatic patient who has allergic rhinitis comorbidity, we will find that the nasal fluid from after nasal challenge test, the leukotriene in the nasal wash is going sky high after a few minutes after nasal challenge test was performed. And then if we know that asthma AR comorbidity has high level of inflammation from leukotriene pathway, and if we compare between double dose of budesonide and adding montelukast to the asthmatic patient who already received the inhaled corticosteroid, the morning peak flow is better in the group that received montelukast adding to the inhaled corticosteroid, better than double dose of inhaled corticosteroid. The second group will be respond better with the montelukast is the asthmatic patient who already have the asthma, exercise-induced asthma or exercise-induced bronchoconstriction. So if we ask the patient at the clinic and the patient have a symptom going worse when they perform exercise, and if we look at the patient with in the children with the asthma in exercise-induced bronchoconstriction, and we perform the exercise challenge test, we will find that the leukotriene level in the urine is going up after 1 to 2 hours after that. So if we compare the using of montelukast to the placebo, montelukast can prevent falling of FEV1 after exercise challenge test in the patient with the exercise-induced bronchoconstriction. And if we compare the treatment modality in asthmatic patient with the exercise-induced bronchoconstriction, we will find that in the placebo group, the FEV1 is falling most up to 26%. If we just use the budesonide, the FEV1 is still falling down close to 17%. But if we use the treatment with montelukast alone or montelukast combined with inhaled corticosteroid, the falling of the FEV1 is least in this group that received the montelukast. Even we compare between the inhaled corticosteroid with the long-acting beta-2 agonist, the montelukast using is associated with the best outcome. It is a study to compare between the montelukast and sometrol or long-acting beta-2 agonist, and we found that montelukast has the best response in asthmatic patient who has exercise-induced bronchoconstriction in children. The next group is the child with the passive smoking. The best treatment is we should advise the family to quit smoking, right? But if we cannot do that, that's a good thing. What the option? If we see the asthmatic patient and we divide it into the two groups, the non-smoking group right here and the smoking group right here, we will find that the level of leukotriene is markedly higher in the asthmatic patient in the smoking group. And then, if we already know the child with the passive smoking tends to be more inflammation from the leukotriene pathway, and if we compare between montelukast and fluticasone in terms of asthma control today, we will find that in the asthmatic patient with history of heavy smoking, they will be respond better with montelukast compared with the fluticasone. So the best option is to quit smoking, but you cannot. The preferred option might be adding montelukast compared to inhaled corticosteroid. Again, we see a lot of asthmatic patients with the severe obesity. And if we measure the urine leukotriene E4 in the asthmatic patient who has a normal body weight compared to the asthmatic patient who has a high body weight or obesity, we will find that the leukotriene E4 is higher in the asthmatic patient who has severe obesity. So that might be a preferred group to choose the montelukast in this kind of patients. And the last group that might be beneficial for consideration of adding or choosing montelukast is asthma in the young. This trial, what we call that infant trial, is the RCT, which is doing in the asthmatic patient in preschool, the younger than 5 years old of age. And they have treatment options to be compared. The first option is the using of inhaled corticosteroid daily. The second option is the use inhaled corticosteroid right immediately after viral infection. And the third option is to use montelukast daily manner. And they compare the outcome. The first outcome is the primary outcome of concern is asthma control day. You will see the result is almost close among the three options arms. If you compare about the daily use of montelukast to the inhaled corticosteroid PRN, the asthma control there is approximately the same. And the best option, you have to choose the daily using of inhaled corticosteroid in terms of incremental improvement of the asthma control there about 5% of time. But what is the concern if you use the inhaled corticosteroid daily in the young child? If we measure the growth velocity, we will find that if we compare between the using montelukast daily with the daily use of inhaled corticosteroid, about approximately 16 weeks or 4 months, the patient who will receive inhaled corticosteroid daily will have a decrease in terms of growth velocity or high velocity approximately 4 millimeters in 4 months, or about 1.5 centimeters a year. So you have to trade off between the high velocity or the 5% increment in the asthma control day. So it is up to you, it's up to the parent to choose the medication with it affect the 5% increment of the asthma control day, or the treatment that might be prevent the high velocity decline for about 1.5 centimeter a year. That is, you have to choose, and you have to advise the parent to choose it too. So in summary, in the patient who might be beneficial if we choose the montelukast as the asthma control is the asthma with allergic rhinitis comorbidity, in the asthma with the severe obesity, the asthma who have exercise-induced bronchoconstriction, the asthma and either active in teenager or passive smoking in child, and asthma in the young or preschool asthma, particularly in the younger than 5 years old of age. And finally, if you read the article, if we read the research, you will find that the research efficacy of the inhaled corticosteroid or even the inhaled corticosteroid combination with long-acting beta-2 agonist have better efficacy compared with the montelukast, but effectiveness is not equally as efficacy. We are treating the patient at the OPD, so we're dealing with the real-world effectiveness, not in the research efficacy anymore. So the real-world effectiveness is equal to efficacy times with compliance, time with adherence to the treatment option. And if we compare between oral medicine and inhaler medicine, we will find that the compliance or adherence of oral medicine usually better than the medicine that you have to inhale them into the body. And another study is the same result. The inhaled corticosteroid will be compliance less than 50%. And if we use the oral medication, the compliance is going over 70%. And if we put it together to see the real-world effectiveness, this is the real-world effectiveness study in the U.S. Medicare, Medicaid, that is the health insurance policy in the United States. We will find that in the real-world effectiveness study, if we use inhaled corticosteroid combined with the long-acting beta-2 agonist, or compare with the leukotriene receptor antagonist. In terms of treatment outcome, the ER visit and the hospitalization is equally the same among treatment options, because you cannot choose the best research efficacy into the patient and expect with the high effectiveness, because in the real world, if you give the good medicine to the patient and the patient do not use that medicine, that is useless anymore. So my take-home message is asthma control is necessary in all asthma. You do not use only short-acting beta-2 agonist alone in terms of asthma treatment anymore, because it makes the patient higher risk to asthma exacerbation, eventually asthma fatal death. And inhaled corticosteroid, to be honest with you, is the cornerstone of asthma control treatment. But steroid cannot completely control inflammation, particularly with the inflammatory by the leukotriene pathway. Some of the asthmatic patients have best response to montelukast rather than inhaled corticosteroid or long-acting beta-2 agonist. That is why asthma treatment should be personalized in each asthmatic patient. That is not thing like a one-fits-all animal. And montelukast should be considered in asthma and AR comorbidity, asthma with exercise-induced bronchoconstriction, asthma with passive smoking, but don't forget to advise the parent to quit smoking as soon as possible, and asthma with obesity. Again, you might have some intervention to reduce the body weight of your asthma too. And finally, asthma in the young children, particularly younger than 5 years old. And montelukast has a better compliance compared with the inhaler medicine and can augment the real-world asthma effectiveness. In administration term, we usually hear put the right man on the right job, right? So in the asthma control team, you should have to put the right medicine into right patient to get the best clinical outcome of our patient. Thank you. So my section is over, and the next section is the better way in order to prevent asthma occurring, because if the asthma already happened, you have to treat them for a long period of time. And the next lecture is asthma prevention with concomitant treatment by Dr. Haritai. Dr. Haritai is a pediatric pulmonologist with the area of interest in asthma. And she is currently an associate professor in the Division of Pulmonology, Department of Pediatric Ramathipadi Hospital, Mahidol University, Thailand. So please welcome Dr. Haritai. Thank you.
Thanks to Dr. Bandan for introduction, and thanks to the organization for inviting me to give a lecture like this. Today I'm gonna talk about asthma prevention with the concomitant treatment. It's very tricky lecture, because asthma prevention is quite difficult. About myself, I'm now the director of the Pediatric Pulmonology Fellowship Training Program at Ramathipadi Hospital, and I did my fellowship training at SickKids in Canada, and area of interest including asthma, aerosol medicine, and respiratory care, cystic fibrosis, and BPD. Just in case anyone from the international would like to contact me about some issues about this, that would be great. Okay, so asthma usually begin in early childhood with the toddlers in the highest prevalence. And usually the wheezing in the early childhood start at the age of 3, that 1/3 of them had at least one wheezing episode in their life. And at the age of 6, half of them has once in a lifetime wheeze, and 1/3 of them has recurrent wheeze. So that's quite a burden. So there was a Eureka cohort that the urban, environmental, and childhood asthma here that follow the child since birth until age of 3 years, and again at the age of 7, to investigate the immunological cause of asthma among the inner city children. So the hypothesis is the high level of exposure to the sensitizing allergens associated with the development of asthma or recurrent wheezing. In the inclusion criteria is among the with the 20% below the poverty level, one of the mother or the father has AR or atopy, and term baby or actually much more than GA of 34 weeks and over. So the result quite surprised that there was an interesting study, like more number of allergen exposure has less probability of the recurrent wheeze. What does that mean? Does that mean like we have to expose to lots of allergen to become more healthier, or we should like play with something that dirty to get more allergen? So here there is the exposure index that by year 1, by the sensitivity, that if we have like a lot more contact of the exposure index, we have less probability to have asthma. So the first year, indoor allergen and bacteria, quite significant that the first year exposure to the cockroach, to the mouse, and the cat allergens was negatively associated with the recurrent wheeze at the age of 3 years with the odds ratio less than 1. That means if you expose to 3 of these things, these sinky things, you may have the less probability to have allergy or asthma. So the first year reduced exposure to the specific bacteria such as the Firmicutes or the Bacteroides was associated with the atopic wheeze. Okay, so here's come up with the well-known hygiene hypothesis that you might already know, that there is some media that mention about why you should let your kids eat dirt. That's kind of stinky, huh? And infants who are exposed to the unsavory things, such as the rodent, pet dander, household bacteria, and cockroach, again, during the first year, is less likely to suffer from allergy and asthma. This is for the general population to understand that the research that I mentioned before. Okay, so this this research was done in Boston, New York, and St. Louis. So living in a home with the mouse and cat dander, a cockroach had the lowest rate of wheezing by the age of 3, living in a home in the messy things. So this is the good news for the housewife, that you don't have to clean your house that often. Just let them a bit of messy, and then you have your excuse that, okay, because I think of my children, that they might get healthier. Okay, that's a good news for me as well. And only 8% of kids in both allergy and asthma stay in very clean house. So too clean is not good for your lungs and your allergies. Okay, this is the concomitant exposure about, this is the, in the red color, this is the contact with the high level of the microbial, and A is the high contact of the allergen exposure. So you can see the red bar is in the highest proportion in the patient without any wheeze or atopy. But in the patient with wheeze and atopy, or both of them, the contact or the exposure of the microbacterial and the allergen is less than the previous group. So that means just emphasize on the research that I mentioned before. So let's talk about the onset and the severity of asthma here. It is multifactorial, with the microbiome, with the endotoxin or the farm exposure, prenatal and postnatal antibiotics, and allergen that I mentioned before, and air pollution, which is the serious problem right now in Thailand. I'm not sure in your country, maybe you face the same problems about air pollution. Can I just ask the audience, is there any country that still have very active problem about the PM 2.5 or air pollution? May I just see your hand? Please raise up your hand, please. Oh, that's just the Thai audience, I think. Okay, so this is still a serious problem that can cause asthma. So if you would like to prevent asthma, you have to concern about these things. Along with Dr. Bandan's lecture, obesity and multifactorial like this, socioeconomic status and psychosocial stressor as well, and smoking. Smoking right now in Thailand has shifted from the tobacco smoke to the e-cigarette. So that's going to be the new things for the young children. Can you guess how old of the children that start to try on the e-cigarette in Thailand? Can you guess how old of them? The answer is 8 years old. They start 8 years old in Thailand already. Because I'm gonna talk about this a bit later. Because of the characteristic of the e-cigarette, right now they shift from like the boring one, like a pen, to something kind of looks like USB port, or kind of looks like candies, and very, very fancy colors as well. So all of these things makes asthma get worse, or even initiate asthma. If the patient or if the mom, the pregnant women, contact all of these things, gonna be I'm gonna summary here, like the protective and the promoting of allergic disease development in the early life. If you have the protective, like if you have the vaginal birth and microbial and fungal diversity, you contact a bit and a small amount and the appropriate dose of bacteria. I mean, not too much, but contact a bit of them. And later birth order, number of siblings, you have many children, not only one child in the family. You have contact in the farm exposure and the endotoxin exposure. This is a protective factors, not having asthma. But this is a promoting factor if you use lots of antibiotics since prenatal or postnatal, contact the air pollution and smoke exposure, viral infection, some kind of specific ones such as the RSV, the human rhinoviruses, and all of these things that is too much of them. How does my cockroach, mouse in the very, very serious amount of them, so you can promote the allergic disease development. I like this article very much. This is from Lancet 2020, which mentioned about the primary prevention of asthma, from risk and protective factors to target strategy of prevention. They mentioned about 3 categories, like a genomic factor, aberrant immune maturation, and the environmental factors. With the combination of these things, looks like a very complicated one, the eosinophilia, Th2, and the food, and the inhalants that I mentioned before, and metabolic disease, RSV, human rhinovirus, neutrophilia, and increase of exhaled nitric oxide, and impair of the lung function. These all factors in the combination to increase the probability to have the complex disease of asthma. Look at this graph. I might orientate a bit. Usually, from at birth, the type 2 immune response gonna be very, very high, and it's gonna be slightly decreased to the normal level, to the steady level of them until age of 2 years. If the patient live in the rural or in the rural or have the rural lifestyle, very natural contact to the farm pets, or eating some kind of raw milk, something like that, raw dairy products, and they're gonna have normal decrease in type 2 sensitivity like this. And they might have some infection a little bit of the RSV, of the human rhinovirus, but not too much, not too often. So there is the development of the adaptive immune response going to be better. But if they shift to the Western lifestyle, sitting in the air conditioning room, playing games all the times, and not exposed to any dirt, and live in very, very clean room, the type 2 response, type 2 immune response, gonna be slower in decrement from time to time. So it may be reached the normal state under when reached the 4 years old, which is longer than expectation, and with the allergen exposure, with very less compared to the previous curve. So this one gonna be the problem. With the prolonged type 2 immunity in early life, gonna be increase the risk of the atopic sensitization, inadequate immune response to the respiratory viruses, leading to childhood asthma. So the viral and bacterial respiratory infection in the first 10 years of life. This is another article from Frontier Allergy 2021, and mentioned about the developmental of asthma in children starting from intrauterine. Here, you may see that if the pregnant women contact to some specific kind of viral or bacterial colonization, Staph aureus, RSV, and then after birth, the kids contact with the rhinovirus and influenza, and the postnatally germs like this. In the first 10 years of life, with the specific species of the virus or bacteria, it can increase, it can become the development of asthma in children. And now they separate the healthy lungs here and the asthmatic lungs with the loss of cytokines and immunomodulator like this. With the asthmatic lungs, they have to infect it with the varicella, H. influenza, or the streptococcus, and Neisseria. But the healthy lung, they just have some kind of the gut immune or the specific germs. This is the good germs, this is the bad one, okay? With the gut microbiome, I mentioned before, the bacteria, viral, fungi, and helminths, at some point, is beneficial for us, for the kids, that if they contact in the small amount, they should be fine. But actually, the gut microbiome is influenced by the mode of birth. Vaginal delivery is better than the C-section. The immune and the diet and the family composition I mentioned before, with their farm lifestyle, that contact of soil, drinking the unprocessed milk, and eat some fermented food. If your kids like to eat cheese, yogurt, and butter, or plant-based fiber, so it may be beneficial for them to not having in development of asthma. So we found that reduced in gut microbiome diversity at 1 month of age was observed in children who develop asthma. So just think about the diet as well. And infant diet is another topic that I would like to mention. So right now it's very famous about the Mediterranean diet exposure that has lower prevalence of asthma in children. What is the Mediterranean diet? I'm seeing right now you start to have some diet. Unfortunately, Thai food is not Mediterranean food, because in the Mediterranean diet, they compose of very high amount of the vegetable, avocado, oil, legumes, whole grains, something like that. And the meat base is usually fish and shrimps. Eat less of red meat, okay, and drink some wine, okay. So, sounds like very, very happy life. So this kind going to be limits of inflammatory response in the airways and reduce risk of asthma at some point. For the food diversity, if you start to feed the baby, just give variety of food, not like something the same, like a boiled eggs, some every day, something like that. And air pollution and tobacco, as I mentioned before. If your child, if the pregnant women contact with the PM, even the smoke from the traffic, they're gonna be the change in the DNA and impact the fetus because of the DNA methylation, oxidative stress, placental dysfunction, leading to IUGR and the low birth weight and premature birth. Premature birth is not good because they're going to have low lung function, increase in inflammation, and the lower alveolar number. That's not good for the lungs and the healthy of the respiratory system. So if the maternal PM and smoke exposure, it increases the risk of asthma by changing DNA, increase the T helper 2 cytokine overproduction, increase in eosinophil goblet cell, and the mucin hypersecretion with the airway remodeling as a result, and the hyperresponsiveness and inflammation. So the Quad AI recommend that the preventive strategy for asthma and allergy, including avoid the dust mites, try to destroy them with the heat and clean room, and breastfeeding, the PETs is kind of controversy, but not to expose infants and children to the tobacco smoke, or right now should be e-cigarette, as I mentioned before. If they start to smoke since intrautero, they have to use some inhaler. With the Clean Air Act that I mentioned before about the PM 2.5 problem in Thailand, right now, it can cause very serious about allergic rhinitis and epistaxis in the picture as shown. Right now in Thailand, we have the PM 2.5 working group leading by Professor Arunvan Pritipan at the Royal College of the Pediatrician of Thailand to try to raise some awareness. And we have some publications about the PM 2.5 exposure that associate with asthma exacerbation in Thailand, which we done the study in Bangkok and in Chiang Mai. And we, right now in my university, Mahidol University, they have some poster to raise awareness of PM 2.5 and e-cigarette for Thai people to understand that. If you don't have the strategy to decrease the PM 2.5 right now, because that's going to be kind of government things, you have to do the nasal irrigation. You have to protect your child with the nasal irrigation like this. Sorry. So this is the kind of do the nasal irrigation that kids can do. This is my daughter at the age of 3. Sorry. And she is doing the nasal irrigation by herself here. So don't push them to do that. Ask them to like a play thing. Okay? So they just say, when they push the saline in, so they won't, she won't aspirate the saline inside, and it's very easy to do so. And with the mometasone furoate, if you clean your nose already, you should use the efficacy medicine to help to protect your child about the allergic rhinitis. Which here I'm going to show you about the data that the mometasone furoate has the lowest systemic bioavailability. That means less side effect compared to the others. And with the highest therapeutic index, with the efficacy over the adverse effect is very high in the mometasone furoate compared to the others. The mometasone furoate demonstrates the high efficacy with the low side effect. And this is the property of the intranasal steroid. There are many kinds of them in the market, but the one you should use or you should pick is the one that can go deep inside the nose. Okay, the length of the spray. This is the characteristic of the spray. The length of the spray is appropriate to reach your adenoid. Okay, and this is going to be protect you from the adverse effect. And the degree of the angle here is about 20 degrees of the angle, which is proper. Too wide is not good. It's going to come out because it not go inside. Too wide angle is spread all over and may have the rhinitis medicamentosa, which is not good as well. And with the asthma that Dr. Bandan mentioned about asthma and the treatment before, we have to concern about the comorbidities such as chronic rhinosinusitis. Here, we compare about the asthma patient with chronic rhinosinusitis and without. As you can see, the yellow bar here is a severe asthma that's going to need step 4 treatment. Because they have the comorbidity, chronic rhinosinusitis, we have the highest proportion of the severe asthma. That means if you would like to treat asthma, you have to treat comorbidities such as the chronic rhinosinusitis, and mometasone furoate is the one that has been proved that has significantly improved in the asthma control test, ACQ-5, and the lung function as well. It's very effective to treat. And treating asthma has a positive effect on the OSA as well. As I mentioned before, if you use the proper medicine and it can reach your adenoid, it is good for you. So my take-home message about asthma prevention is actually you have to prepare since before having child. Just calculate about the birth timing. Try to avoid the giving birth at the RSV season. So let's think, when should be the fertilization, and then supplementation of some vitamin, fish oil, Mediterranean diet, rural lifestyle, a little dose doesn't hurt, and concomitant asthma treatment to treat comorbidity, and especially for allergic rhinitis. And I would like to stop here. Thank you.
Thank you, Dr. Harutai, for your clearly and informative talk. And since we are running out of time, so you can ask any question in person after the end of the topics. Finally, I have to thank again the organizer for supporting this luncheon symposium, so I can give the floor back to the MC. Thank you.